have been a very good. So by and large, there has been a very good response, and thank you for the candidates who have submitted your answers today. Okay, so we will definitely go in detail about the candidates and get back to you as and when time helps us. But for the few answers that I could look across, especially like Madam was telling, the questions that we had particularly set, you have given fairly good enough points to at least give you a passing mark. Okay, so congratulations on that aspect. That, yeah, most of you who have given the answers, you have written bare minimum to little more than that. So I think so you still have time to just go back and brush up and revise those topics. Okay, so along with this, time management is very much necessary. We knew that this paper is lengthy, I'll accept that. We did this on a purpose, telling that, okay, if at all you are facing such a paper in the final exam, you'll know how to manage it. Okay, so is there anything else that any of the other panelists would like to speak about? Dr. Srihari and Dr. Bhuvana is also joined in. I think so. You guys can mute and you can add in any valid points, and after that we'll start with the debrief. Most importantly, the debrief will not go like a class. We'll just show you what is the answer and what is expected out of you. So don't anticipate a class-like scenario because it would be too long. Okay. So, Dr. Srihari and Dr. Bhuvana, anything you guys want to add
Yeah,
in?
yeah. Good evening to all. So, just a small experience that I had. So, thing is that especially for the first paper, you will be extremely stressed out. So that's why they say to go to the center early and then get in and sit in for half an hour. So for me, what I had was I like out of 10 questions, I was able to be confidently able to write seven. So the problem was I randomly started at a different number and then I kept moving to different questions. So the problem was I had written one question in the wrong number, and I realized it after I had completed 3.5 pages of it. And to be honest, at that moment, I had some mini heart attack. I asked the coordinators if I could have an extra paper or any new sheet and all. They told it's not possible because it is QR coded and all, and they've already noted and they've taken us signatures and all. So then somehow I had to manage one full question within 1.5 pages, and by God's grace, I passed that paper. So just to make you all aware, be calm at that point of time and go very systematically and plan your answers. That will help you a lot.
True, true. I think so. That is what most of us have faced. I think so. Be calm. That is the goal. Okay, so relax. Look into the things. And best way would be just mark the number of pages, and you just make a point telling that if the page number comes as six, right? Just put your question number there. When you're given your answer booklets, they will be given earlier. So as soon as page number six comes, just put a question number two there, so that you know that, okay, this question has to come. That's one way that you can be a little more safe and calm about it, and not make any errors in the last minute because of your stress, etc. um, Anything else anyone wants to speak, or else I think so it's fair enough that we started. It's already 4:15, and a good deal of 45 candidates have joined. Anything else, Niharika ma'am? I think so we can start off. We are not going in an order, guys. We are going it as and when the questions approach. Okay, so they will share the question number initially, and then we will discuss. Okay, so we are not going in an order as it was given in the paper. Okay, so firstly we'll start off with Dr. Niharika with the questions. Over to you, ma'am. Thank you.
Thank you, Darshan. My screen visible, Darshan?
Yes, ma'am, it is.
Okay. So, so we have actually divided the questions equally. So we will be dealing. So all keep your answer sheets ready. Take a pen, and we are going to tell you how you should write it. And if you have written in the manner what we told, you can give a mark for that. Okay, so you can self-assess your own papers. Okay, so I'll be discussing about the multimodal neuromonitoring, the status epilepticus, sedation in ICU, and the newer modes of ventilation, which is a short note on APRB. So some of you people have actually sent the question paper answer sheets, right? So I have seen. So most of you people for multimodal neuromonitoring, yes, most of you people wrote about invasive, non-invasive. Yes, good. But that is only about the neuromonitoring. Okay. So what is multimodal neuromonitoring? So we also have written it in the page. Okay. So I have completed this multimodal neuromonitoring in 2 pages, and the remaining 3 pages will be in the acute ischemic stroke. Okay. So before writing your answer, just you have to think what you need to write. Okay. If they have asked about multimodal neuromonitoring, yes, I might write in this headings and I should complete in this page, these many pages. Okay, otherwise, if you write multimodal neuromonitoring or neuromonitoring, you'll be writing about ICP, you'll be writing about um, CPP, TCD. So you might finish some 3.5 pages over there, and you will get only 1.5 page for your acute ischemic stroke. Okay, so before writing the answer, just be prepared that yes, I should complete it in this time, and at this page, I need to stop my question. Okay, so sorry. Um, okay. So first you should write what is multimodal neuromonitoring. So definition, it carries 1 mark. So what is the definition of multimodal neuromonitoring? It is nothing but an integrated combination and display of non-invasive and invasive modalities permitting tailored treatment for individual patient. That is nothing but it is a personalized approach of monitoring a neuro patient. So if you have written this definition, you can give 1 mark for this. And what is the goal of this multimodal neuromonitoring? In order to prevent secondary brain injury due to ICP surge, cerebral hypoxia, cerebral hypoglycemia, or any other excitotoxic damage due to recurrent or prolonged seizures. Okay. So if you write the goal, it's okay. Otherwise, you can write the definition and then go to the various multimodal neuromonitorings. So basically, what is multimodal neuromonitoring is you will be monitoring 3 to 4 parameters together. Okay. So you'll be monitoring ICP, you'll be monitoring about the, if you see here, so this is a intracranial triple bolt, okay, where they are monitoring 3 things together. Okay, so they are monitoring the ICP, okay, they are monitoring the brain tissue oxygenation, and they are doing even the cerebral microdialysis. So everything will be connected to a single device, and you're going to get all the parameters in that device. So that is about multimodal neuro monitoring. Here also, if you see, there is a single monitor and there are 3 things which you are monitoring. Okay, so here you will be monitoring about the brain tissue oxygenation. So this green color one is the NIRS monitoring. And if you see the blue color one, this is nothing but the jugular venous oxygen saturation. So all the values have been depicted here. So at a single go, you're actually monitoring the multi-parameters. So that is known as multimodal neuromonitoring. It is not just monitoring a single parameters like ICP or TCD. Okay. So that is the basic of this question. So this multimodal neuromonitoring can be divided into 5 major headings. Okay, so cerebral flow directed techniques, cerebral autoregulation, cerebral oxygenation, cerebral metabolism, and cerebral global function. Okay, so you have to write, and each of it has been further classified into what we are measuring, whether we are measuring the global physiology or whether we are measuring the local physiology. Okay, if it is a cerebral flow directed techniques, so the global physiology things which we measure is the ICP and CPP, whereas locally what we measure, the parameters which you measure is the TCD and the thermal diffusion flow cytometry. To measure the cerebral autoregulation, we use 3 indices, that is pressure reactivity index, mean velocity index, and oxygen reactivity index. To monitor the cerebral oxygenation, globally we monitor the jugular venous oxygen saturation, and locally we'll be monitoring the PB2O and the NIRS. For cerebral metabolism, the global physiological measures would be S100B and the NSE. And for local physiology, you have the micro dialysis or any imaging modality like a CT or a MRI. And to know the cerebral global function, we use EEG if or continuous EEG monitoring. So these are the parameters of the multimodal neuromonitoring. So if you're classified like this, then you can allot 2 marks for this. So basically this multimodal neuromonitoring carries 5 marks. So 1 mark for definition, 2 marks for the different modalities. Now, instead of writing about a single thing, so ICP, ICP can be monitored by this is the gold standard. So the normal value of ICP is this much. So if if you write like that, I think your time will be wasted a lot. So instead of that, if you put it in a table manner, and write only the most important things. That is more than enough. Okay. So this multimodal apparatus, okay, so we will be discussing about some important things. For example, the modality of ICP. Okay. So how do you measure it? Either by EVD or intraparenchymal monitors. What should be the physiological range? It should be less than 20 and the threshold is more than 20 or 25. And what is the clinical significance? It is a marker of cerebral edema and impending herniation. Okay, so in an easy way, you can write this, right? So this is about ICP. In the same way, you can write about CPP, cerebral blood flow. How do you monitor? If it is TCD, for example. Okay, so you are going to monitor the velocities, mean velocities of the MCA, and you will measure the Lindy-Gard ratio. Okay, so you write the physiological ranges. And what is the threshold of each thing? You can just mention it. And why do we need it? Because we need to detect the vasospasm and DCI in SAH. That is a clinical significance. Okay. Similarly, CPP. So what is the normal physiological range of CPP? And what is the threshold? If it is less than 60, yes, there is a chance that the brain metabolism is completely hampered. Okay. So similarly, cerebral oxygenation, we measure the SGVO2. The normal physiological range is 50 to 80 and the threshold is less than 50 or more than 80. Both are very dangerous. So basically this indicates global ischemia if it is less than 50 and global hyperemia if it is more than 80. Similarly, in the cerebral metabolism, what we use is the microdialysis. So you should know what is the normal values. At least remember the lactate pyruvate ratio. Okay, the normal ratio should be less than 20, but if there is an anaerobic metabolism happening in the brain, then the threshold would be more than 40. Basically, this indicates brain energy supply and demand ratio. Okay, and if this LPR ratio is increased, it indicates anaerobic metabolism. Okay, so this will carry the remaining 2 marks. So what I would suggest is for all the standard questions, this is okay, multimodal neuromonitoring. I think most of you people will not be knowing about it, a relatively new concept. Yes, to write it in this way would be a difficult thing. I do understand. But the other standard questions, it could be acute ischemic stroke, or we have given a brain death question, brain death organ management, donor management. So all so many standard questions. So if you get a standard question, you should be able to write it in a proper way. Where to put tables? Okay, if there is a pathophysiology, how to write it? Okay, so that you can actually save your times. Because standard questions to write, you require less time. You require more time for those questions which you actually do not know properly. Because you need to think about it. And whatever few things you know, you should put it in a proper way so that you will get at least the minimum marks. So you have to keep more of the time for those questions which you don't know and keep less time for the questions which are straightforward, which are very standard. Don't write additional things. Okay, don't keep on writing about the ICPS. You know, you are writing, you put the waves P1, P2, P3. If you know only about ICP in multimodal neuromonitoring, then only you might get 1 or 2 marks. That's it, not much. Okay, so be specific in whatever you write. Okay, so this finishes my multimodal neuromonitoring. So definition 1 mark, various modalities 2 marks, and about each of the thing, mentioning its physiological range, threshold, and what is the clinical significance, 2 marks. 2 pages, 5 marks, done. Okay, so this is about the first question. Now the next question is about, I think this question has been already discussed by Srihari in the top classes. So he has given it in a very nice way. So what they've asked is about status epilepticus, definition, causes, and the management. So it was totally asked for, I think it was asked for 5 marks. 6 marks. Okay. So if you're writing about status epilepticus definition, so everyone knows it is being given by the, if you write the society, it is very good. So Neurocritical Care Society has given this definition. So 5 or more minutes of continuous seizures or 2 or more discrete seizures between which there is incomplete recovery of consciousness. Okay, you will get directly 1 mark. Okay, if you have time, or if you, they won't give you much marks if you write, yes, these are the types: refractory, super refractory, and definitions of super refractory. How much ever you write, you will get only 1 mark. Okay, so if you write it, if you don't write it about the refractory and super refractory, you are going to get 1 mark if you have given a proper definition of this status epilepticus. Okay, now next about etiology. So etiology, yes, most of you people have written it in a nice way. You have put it in a flow chart or a arrow marks and all. Yes, good. So divide it properly. Okay, so you can divide it as an acute causes, or it is remote or progressive causes. So in acute causes, the most important things are stroke, any CNS infections, acute TBI, cerebral anoxia post cardiac arrest, any metabolic disturbances, sepsis, drug withdrawal, and autoimmune encephalitis. Okay, at least try to write the important things. Okay, at least 3 to 4, more than enough. And if it is a remote or progressive causes, any pre-existing epilepsy. And now there is a breakthrough seizure because of some intercurrent infections or because of the non-compliance of the drugs, or pre-existing tumor, or if there is any remote pathology like previous stroke or TBIs which are leading to scar epilepsy. Okay, so this is the etiology. If you have written, you are going to get 2 marks. Now next comes to the management. So management of status epilepticus basically begins with the investigations, the basic investigations. So you're going to send the metabolic panel, CBC, renal function tests, LFTs, and additionally better to send toxicology, drug levels of anti-seizure medications. Okay, so basic investigations you're going to write. Then important thing, check the blood glucose. Okay, so if the patient has hypoglycemia, then give thiamine first, followed by the dextrose. Then comes your ABC. Okay, airway you have to monitor, breathing you have to see, then see the circulation, obtain the IV access. And the first drug which you give here is the lorazepam. Okay, so you can either give lorazepam, and alternatives would be midas and diazepam. Need not to remember the doses of everything in your written exams. So write about one thing, proper dose. Okay, if you want to write about midas, write proper dose. Loraz, write about a proper dose. So mention the dose properly, and you can just mention, yes, these are the alternatives like midas or diazepam. Okay, then if the seizures do not stop in initial 5 minutes, then it is known as initial status epilepticus. So you can repeat a dose of lorazepam, same dose which is mentioned above, and still the seizures won't stop within 5 to 10 minutes. It is known as established status epilepticus. Okay, so just put it, put it in a box or a rounder form. So basically you should highlight whatever you want to tell, you need to highlight it here. Okay, so if the seizures have not controlled, then you have to investigate for the underlying sorry, if the seizures have been controlled, then you have to investigate for the underlying causes by doing any neuroimaging, EEG, and everything. Suppose if the seizures have been continued, then you have to give your first line drugs. So what are your first line drugs? Fosphenytoin, phenytoin, sodium valproate, or levetiracetam. Try to remember at least 2 doses, okay, either phenytoin or levetiracetam, which you usually give. Okay, write it in detail. And suppose if the seizures are, you are not able to control it, then you have to use your second line drugs. So what are those second line drugs? You can use lacosamide or phenobarbital. Post that, if the seizures are controlled, yes, you have to evaluate for the cause of seizures. If not, then if the seizure is persistent for more than 30 minutes, it is known as refractory status epilepticus. Okay, if you just stop with the second line drugs also, it is more than enough, because we have just asked about status epilepticus. Okay, but if you want to mention little and you want to show that, yes, I know further how to manage it, you can just mention, yes, if the seizures persist for more than 30 minutes, it is known as refractory status epilepticus, where I would be monitoring the continuous EEG. If patient was not intubated, I'll intubate and gives drugs such as midazolam, propofol, and thiopenton. You need not to write the doses here. But if they've asked about refractory status epilepticus, then you have to complete till this much. You should know the doses also here. Okay, and suppose the seizures are persistent for more than 24 hours, it is known as super refractory status epilepticus. Finish. It's just for 3 marks, so you're going to get 3 marks if you write this much. Okay. So status epilepticus causes 1 mark, etiology, definition 1 mark, etiology 2 marks, and management 3 marks. Completed in 3 pages. Okay. So my next sub question in this same thing was sedation in ICU. Okay. So yes, sedation in ICU is also one of the standard question. So sedation in ICU, analgesia in ICU, and neuromuscular blocking agents in ICU. These 3 are standard questions. So I actually request you, you need not to write every drug in detail. Don't write about midazolam in detail. Don't write about ketamine in detail. Okay, so whatever, because you don't have that much time. It is only for 4 marks. So you can't just keep on writing because you have to write so many other things also in sedation. Okay, so first, if possible, just 1 second. So definition, you're going to write what is sedation. It is nothing but the depression of patient's awareness to the environment and reduction of his or her responsiveness to external stimulus. And the effect of sedation on basically depends on the different doses of the sedatives which we use. So it has anxiolysis effects, amnesia effects, analgesia effect, and if you give it in a larger doses, it can also lead to anesthesia. And sedation protocols are considered one of the best practice guidelines, and this PAD guidelines also recommend a light sedation in ICU. Okay, so definition, and if you write this much, you are going to get 1 mark. Now, what are the uses of sedation in ICU? Why do we need it? So first, it allows patients to tolerate painful or distressing procedures, to optimize mechanical ventilation, to decrease the ICP neurosurgical patients, and it controls agitation. Okay, so if you write the uses, okay, you might get 1 more mark. Now, important is what are the commonly used sedative agents. As I told, sedation, analgesia, neuromuscular blocking agents. If you have time, just prepare a table like this. You need not to write about midazolam in detail, dexmedetomidine in detail, not required. Just put a table, what are the important that has to be mentioned. If you do this, and if you write, you see a lot of time difference. I mean, you can save a lot of time, right? So commonly used sedatives, they can be divided into hypnotics or analgesics. So midas, dexmedetomidine, propofol. You can write the time to onset, what is the loading dose, what is the maintenance dose, and what is the half-life of each. Okay. Similarly, analgesics, you can use morphine, fentanyl, ketamine. Okay. And you can give the time of onset, loading doses, maintenance doses, and half-life. So if you write this, you're going to get 2 marks. Okay, rather than if you're going to write each of these medications, then you see you are going to waste some 10 or 20, 15 minutes there only. Okay, so write it in a proper way, especially when they ask about these drugs. Okay, now next, what are the side effects? If you want to mention, yes, just you can mention causes hypertension, respiratory depression, arrhythmia, sleep disturbances, drug withdrawal, or in some cases delirium. Now important is how do you monitor this depth of sedation? So I've just classified it. Okay, everyone, yeah, those who have submitted the answers, you have written about RAS. Yes, that is good. So just if you put it in a better way, so subjective clinical assessment and objective physiological assessment. So the subjective clinical assessment, you have 2 scales, the RAS scale and the sedation agitation scale. Okay, for objective physiological assessment, you have the BIS. Okay, you have the auditory evoked potentials and you have the patient state index. Okay, so if you put it in it looks good, right? Then this carries 1 mark. Okay, if you mention RAS also, it's not a thing, but don't sit and write about RAS in detail. Okay, just mention it, it's more than enough. And just a note on how to approach sedation in ICU. If you can just write it if you have time, otherwise it's not required. So light sedation should be maintained, use protocolized care, daily sedation interruptions are required if you don't have a protocolized care. use caution of these drugs in renal and liver failure, and Dexmed is increasingly preferred in delirious patients requiring ongoing sedation. And if you have some time, put some evidences for these drugs. Okay, especially as I told, dexmedetomidine is increasingly preferred nowadays. So put some 2 to 3 evidences. Okay, like you have the Midex Prodex trial, you have the Spice 3 trial, you have the MENS 2 trial. Okay, so just put, and if you know anything about it, write just one line. Okay, so definition, and it carries 1 marks. Why do you use it? Sedation in ICU will carry 1 mark. Commonly used agents, 1 to 2 marks. You take it as 2 marks. And the remaining 1 mark for to monitor the depth of sedation. If you have written this, then you're going to get 4 marks. Okay, these are some additional things. Side effects, if you have just 2 to 3 side effects, you write approach need not require evidences, at least to mention the evidences. That's more than enough. So you're going to get. So this we completed in 2 pages. Okay. Now my last question is about the newer modes of mechanical ventilation. You have to mention and write a brief note on APRV. Yes, most of you people have written about the newer modes of mechanical ventilation, but I would be more happy if you would have classified it and have written it. Okay, so this carries 3 marks for mentioning it. So I have basically classified it into conventional modes, which you all know need not to write. But this newer modes are classified into biphasic pressure modes and dual control modes. In biphasic pressure modes, you have the BiPAP or the bilevel, APRV, and high frequency ventilation. In dual control modes, which are also known as closed loop ventilation. So if they ask about closed loop ventilation, you have to divide this and write any one of them. Okay. So this closed loop ventilation is further divided into intra-breath variation and inter-breath variation. In intra-breath variation, you have volume assisted pressure support. Okay. And you have the proportional assist ventilation. In inter-breath variation, you have again pressure limited time cycled, you have pressure limited flow cycled. So in pressure limited time cycled, you have the PRVC, you have the variable pressure support ventilation, you have the adaptive support ventilation, and you have the auto mode. Okay, in pressure limited force flow cycle, you have the volume support ventilation. And the other, most of you people have written as NAVA. Yes, NAVA will not act with any of these. It will not depend on pressure, time, flow, nothing. So it is basically from the brain. It is neural respiratory output. So depending on that, this is NAVA. And there is something known as Neo Ganesh, which is nothing but a closed loop modification of the pressure support ventilation with integrated artificial intelligence. So this is how you classify the newer modes of mechanical ventilation. Okay. So this carries the 3 marks, and then comes the APRV, which is for 7 marks. Okay. So as we all know, APRV is airway pressure release ventilation. So you should know the definition. What is this APRV? And most of you people, when asked for just mention the newer modes of mechanical ventilation, you people have written why there is a need for newer modes of ventilation. Okay, but I think that classifying this and writing would be more better, because you will not get any additional marks. Why do you require newer modes of mechanical? What is the need? You will not get any additional marks also if you write. Okay. Now coming to the APRV. So if you should write the definition. If you write the definition, you're going to get 1 mark. So what do you want to write in your definition for APRV? So it is nothing but a pressure controlled mode of ventilation which delivers almost a continuous positive pressure with intermittent time cycled short releases at a lower pressure. Okay, so you have to mention it as pressure controlled mode of ventilation. CPAP, continuous CPAP is there, and it is one of the spontaneous ventilation. Okay, here spontaneous ventilation is encouraged, and you maintain a relatively high mean airway pressure. Hence, it is also known as open lung ventilation. Okay, so if you mention these 4 words, pressure controlled, continuous, CPAP, spontaneous ventilation, and open lung ventilation, yes, then they'll be more happy to give you the marks. Okay, so definition, 1 mark. Now coming to the variables. Okay, so you have the 4 variables which you adjust here: P high, T high, P low, T low. So what are this? I've written it. You most of you people know about that. So put a diagram and just mention what are these. So if you want to write P high, put a bracket here and write, yeah, it is the highest level of pressure applied to the respiratory system. So you can just mention in this diagram only, put a bracket and just mention what is P high, P low, T low and T high. So there you will get one more mark. Now how to initiate this APRV? Okay. So you have something known as this Hebash's recommendations for initiating APRV. So there are lots of recommendations. Most people do it in a different way, but most commonly, common way of following the APRV is about this Hebash's recommendations. So first you have to set the FiO2 to 1 and then adjust it later. So first is P high you need to set, okay, which is nothing but the current plateau pressure. So if you have kept the patient in volume controlled ventilation, so you check the plateau pressures. If it is around 26 or 28, maximum will be 30 according to the ARDS protocol. So if it is 28, then change to APRV mode, adjust the P high to around 28. Then P low is always 0. T high, usually it is set between 3 to 8 seconds. The Habash's recommendation, they usually start with 6 seconds. And T low, the range is around 0.3 to 0.8. The Habash's recommendation is around 0.8. So this is the initial settings of the APRV. Okay. And they also tell that you have to while setting the T low has to be set short enough to, sorry, the T low has to be set short enough basically to terminate the, just 1 second. So it should be to terminate the expiratory flow at approximately 75% of the peak expiratory flow. So this can be checked in the flow time graph. Okay, and you need to stop the neuromuscular agents after you start the APRV mode because you are going to encourage the spontaneous breathing. And in all modes, as you need to tolerate the hypercapnia, maintain a pH of more than or equal to 7.25. Okay, so just write the settings. What should be P high, T high, P low, T low. Okay, that will carry 1 mark. Then important is the troubleshooting with APRV. Okay, so if there is hypoxemia or if there is hypercapnia, how do you manage it? Okay, so there's big and lots of tables are there. It's written in a detailed manner. So don't write it in a detailed manner because you won't have much of the time. So if there is an hyperoxemia, reduce the FiO2 initially to around 40 to 50%. Still there is persistent hyperoxemia, then you reduce the P high. Okay. So if there is hypoxemia, that is very important. So if there is hypoxemia, don't increase the FiO2 directly. First, you need to increase the P high by around 2 centimeters of water. Then observe and see if your hypoxemia resolves. If not, then you can increase the T high by 0.5 to 1 second. Okay. Still, if you have increased the T high to more than 10 seconds, suppose you have set it at 8 seconds, 0.8 seconds. So I'm sorry, you have set it at around 8 seconds. You have increased to 10 seconds. If it is more than 10 seconds, still if you feel that, yes, there is persistent hypoxemia, then you start reducing the T low by 0.2 seconds. Okay. If nothing is working, then finally you try to increase your FiO2. Okay. Suppose if there is hypercapnia, okay. So as I told, first we should ensure that the patient is breathing spontaneously. If you give deep sedation or if you're paralyzing the patient, there is no use of APRV mode. Okay, so first ensure that there is spontaneous respiratory efforts. Then you try to reduce your T high by 0.2 seconds to a minimum of 3 seconds. So minimum should be 3 seconds. Okay. And you also need to check if there is any lot of secretions in your ventilator circuit or HMA filter, everything. So try to change them. This is how you correct hypercapnia. And hypocapnia, for which you need to increase your T high by 0.2 seconds. That's it. So this is a simple way of troubleshooting the APRV. Now how to wean from APRV. Okay. So troubleshooting will carry 2 marks and your weaning will carry around 1 mark. So weaning, first decrease the FiO2. As I told, if you decrease the FiO2 to 0.4 to 0.5, the 40 to 50%, then you start reducing the P high 2 centimeter every 2 to 6 hours. Okay. Suppose you have kept the P high as around 26. Okay. So every 2 hourly you try reducing 2 centimeters of water. And once you have reached around 20 centimeters of water of P high, then try increasing the T high, okay, by 1 to 2 seconds. Okay, as you increase the T high 1 to 2 seconds, at a time both P high and T high will match together, where the patient will then be in a CPAP. Okay, so if the pressure is less than 10 centimeters of water, then you can try weaning this patient. Okay, that is one of the method. Okay, if you write that much is more than enough, or if you want to remember in one more, then if the P high is around 12 to 15 centimeters of water, so you have reduced, then you brought it to around 15 centimeters of water. Okay, then you can switch to any of the conventional modes and then try to wean this patient off. Okay, so you can directly wean from APRV, or you can convert the patient into the conventional mode and then wean the patient. So any one of it. Okay, so if you write till 0.3, you're going to get 1 mark. Then if possible, write about the contraindications where you don't want to give an APRV mode. So if there is a profound cardiovascular instability, severe bronchospasm, if there is a bronchopleural fistula, untreated pneumothorax or restrictive lung disease, then these are the contraindications. If you have time, then write about some advantages and disadvantages of this APRV mode. Okay, so that also carries around 1 mark. Okay, this is how you write the APRV mode. Understood? Okay, thank you.
Thank you, ma'am. I think so. Next, we have Dr. Bhuvneshwari taking over. If there are any doubts, you can feel free to reach us out even in the WhatsApp group or in the chat box given below. It was a wonderful thing that we looked into. Make sure that at least if you have answered 70% or 60% of whatever madam has shown, that should be good enough. But yeah, it depends on the examiner and what is the key answers given by NB. So, if there is anything that you guys want to ask, please feel free to write down in chat boxes in between. Okay. Hi, Bona.
Hi, sir. Hi.
Hi.
Could you see my screen, sir?
Yes,
Yeah,
Bona,
Bhumi.
it's visible. Yes.
Hi, good evening, all. I think most of the points were told by Darshan sir and Niharika ma'am. One thing is that as much as possible, when you read a question, you keep some subsections in your mind, what you're going to write in that subsections, and bullet points, flow charts, tables, and simple diagrams would definitely gain you a better mark, because when they see the paper, they should know that you understood the concept and you're writing it to the point. And if suppose a generalized topic is given, for example, a paracetamol poisoning, something like that is given without any targeted questions, then definitely you have to make the subsections and answer accordingly so that you get the full score. Okay, so we'll go to the specific questions given to me. So I'll be dealing with question 7, 8, and a part of question number 10. So the first question is question 7A, that is augmented renal clearance in critically ill. So I have created the subsections as definitions, risk factors, mechanism, and how will we identify the ARC and its clinical significance. So this will give you the 5 marks. So definition, augmented renal clearance is defined as increased renal excretion of circulating solutes and drugs. And by creatinine clearance, it is defined as more than 130 ml per minute per 1.73 meter square. So overall, there will be increased glomerular filtration, increased renal tubular secretions of anions, and increased renal tubular reabsorption. What are the risk factors? Age less than 50 years, male gender, recent trauma, polytrauma, febrile neutropenia, and less severity of the illness. For example, SOFA score less than or equal to 4, less Apache score, less SAP score, and increased diastolic blood pressure, increased cardiac index, and lesser vasopressor use, lesser Lasix use, and lesser positive fluid balance. Coming on to the mechanism, ARC has various mechanisms. Number 1, whenever there is increased blood flow, or because of any ICU interventions like fluid, vasopressors, there will be increased cardiac output, increase in the renal perfusion, and increase in the renal filtration. Then comes SIRS, trauma, burn, where there is increased cytokine, increased inflammation, decreased vascular resistance, and increased renal blood flow. And coming on to the third mechanism, that is the renal functional reserve, where in young patients who may have increased physiological reserve, they will have a better renal clearance. Then comes brain-kidney crosstalk, where whenever there is a brain insult, like any traumatic brain injury, there is increased atrial natriuretic peptide, which could increase the glomerular filtration, increasing the diuresis and the natriuresis. Then, as in case of hyperdynamic circulation, very obvious, insert sepsis and burns. So we know that ARC is specifically important in septic patient. That is why I have put this flow chart, because it can cause subtherapeutic dosing. We have to modify the dose according to the ARC in sepsis patients. That is why, as a common scenario, I have put this flow chart. Even if you skip it, it's all right, but it is better if you put it. In sepsis and antimicrobial levels, in sepsis, we know there is increase in the cardiac output, there is increase in the clearance of the drug, and at the same time, there is capillary leak because of vasodilatation, which may cause overall augmented renal clearance and low drug concentrations, where you may have to give a higher dose of antibiotics, meaning the loading dose and higher dose. And sometimes if the patient has normal organ function, then you need not modify any dose. But if the patient has any end organ dysfunction, then the patient can end up with toxicity, where you may have to reduce the dose of the antibiotic, which is the importance of augmented renal clearance, especially in critically ill septic patient. Coming on to identification of ARC, we can measure it. We can measure the ARC by means of measuring creatinine clearance, or by means of eGFR, or by means of exogenous markers, or by scores. Scores like ARC score and Arctic score are used to measure the augmented renal clearance, which has better sensitivity and specificity. You can put a table simply just to make sure they understand what you're writing. ARC score consists of age, especially age less than 50 years, which carries 6 points. And in trauma patients, 3 points. And SOFA score less than or equal to 4 is 1 point. Any score between 0 to 6 is low risk for ARC. Any score between 7 to 10 is high risk for ARC. Coming on to Arctic score, they take this creatinine value, male gender, and age factor, where if it carries more than 6 points, there is high risk, and less than 6 points carries low risk. So what is the clinical significance of ARC? Mainly the related to the antimicrobial impact on the drug pharmacokinetics, where that could be subtherapeutic doses, especially with beta-lactam antibiotics, where there is increased risk of treatment failure and increased risk of antimicrobial resistance because of the subtherapeutic doses, challenges with the drug dosing. So it may encourage us to create a personalized protocol for each patient based on their augmented renal clearance, and also will encourage us to go ahead with the therapeutic drug monitoring because of variable therapeutic levels of antibiotics in ARC patient. So this completes the ARC question. Going on to the second question, that is endothelial glycocalyx in critical illness. So again, the subtopics we should think about is what is EGL, what are the functions of EGL, and what are all the conditions which could shed the EGL, and how do we preserve the EGL. So EGL, what is EGL? It is a complex negatively charged gel-like layer on the luminal side of the vessel of the endothelial cells, which measures about 0.5 to 2.5 micrometer thickness. It forms the basic skeleton that interacts with the plasma constituents, forming the endothelial surface layer. And just below the endothelial glycocalycial layer, there is a protein-free space, which is called subendothelial glycocalycial layer, which helps regulating the vascular permeability. So a simple diagram about what is in EGL, what is the sub-EG space, will gain you a better mark. So what are the components of the EGL? It consists of glycoproteins, proteoglycans, and glycosaminoglycans with associated plasma proteins, including albumin. So what is the function of EGL? It adsorbs the positively charged regions of the plasma protein so that it retains the plasma protein to create that skeleton. It regulates the vascular permeability and also endothelial integrity. It gives a barrier function with the help of the subendothelial glycocalycial space. It has antithrombotic and profibrinolytic function because it binds heparin sulfate. There is increase in the inhibition of thrombin and some of the coagulation factors. And there is also anti-leukocyte or neutrophil addition function, where cellular addition molecules within the depth of the intact glycocalycial layer is seen. So it does not create any unnecessary reactions because of these molecules. Coming on to the importance in critical illness. So shedding of the endothelial glycocalycial layer happens due to the inflammatory cytokines because of ischemia, reperfusion injuries, trauma, sepsis, hypervolemia, hyperglycemia, hypernatremia, or some of the fluids or colloids we administer, like the synthetic colloids, hydroxyethyl starch. So shedding can lead to capillary leak, edema, hypercoagulability, inflammation, platelet aggregation, and loss of vascular responsiveness. So with respect to individual condition, in trauma, the EGL damage is also called as endotheliopathy of trauma. Just remember this name. It can be asked as a short note. I don't know. It can cause hyperfibrinolysis and it can cause increased mortality. So resuscitation with 0.9% NS worsens the damage. In case of hypervolemia, there is increased ANP causing worsening of the shedding. In sepsis and AKI, there is SIRS, capillary leak, and damage to the EGL. In microcirculation tissue reperfusion, there is increased edema, hypoxia, organ dysfunction causing damage to the EGL. In hyperglycemia, there is increase in the reactive oxygen species causing increased EGL shedding. In hypernatremia, because of the electrolyte disturbances, there is destabilization of the EGL. So what are all the EGL preserving therapies available? We can use balanced crystalloids, FFP, and albumin. And some of the antioxidant therapies are under trials, like vitamin C, ANP antagonist, antithrombin, protease inhibitors, hydrocortisone, hyaluronate supplementation, and sevoflurane preconditioning can reduce the oxidative stress. So this completes our question 7A and B. Coming on to question 8, that is paracetamol poisoning. So it is like a generalized topic. So you have to know what you have to write. Just because you know everything about paracetamol, you cannot just write unnecessary things and waste time on one question. So you have to have your subtopics ready. So few points on it, like bullet points and tables and diagrams as necessary, which will gain you marks. So paracetamol poisoning, question 8A. So paracetamol is an aniline derivative. It is an antipyretic and analgesic. It has weak COX activity. If you skip these two lines, no problem. Just if you write a better picture. So the toxic dose is more than 10 grams. That is 200 mg per kg as a single injection. Or more than 6 grams. That is 150 mg per kg for 24 hours. At least for 2 consecutive days. So what is the pathophysiology? Paracetamol metabolism can be of 2 ways. The majority of the metabolism is through glucuronidation and sulfation, where paracetamol is converted to non-toxic water-soluble metabolite and gets excreted into the urine. And the minimal pathway is that cytochrome P450 pathway, where enzymes like 2E1 and P1A2 and 3A4 is involved, where paracetamol is converted to NAPQI, which is a toxic metabolite. But in normal cases, it binds with glutathione and cysteine residues are formed and it is easily excreted. But in overdose, what happens? This primary pathway gets saturated and this NAPQI pathway becomes the dominant one because there is also exhaustion of the glutathione stores, overall leading to increase in the NAPQI level. There is NAPQI adduct formation, which can cause oxidative stress and mitochondrial dysfunction, overall leading to hepatocyte damage and necrosis. So coming on to risk factors, especially in patients who have had massive overdoses, who are already having ethanol or abuse history, use of enzyme inducers, and delayed presentations where there is staggered doses and chronic accumulation, And in patients with glutathione depletion because of malnourishment, anorexia, alcoholism, or any other underlying liver injury like HBV, HCV, malignancy, or genetic polymorphisms because of enzymes which can break down the drug causing DILI. All these are the risk factors for paracetamol poisoning. Coming on to clinical features, so it can be divided into 4 stages based on the day of the toxicity. Day 1, the first 24 hours is again the stage 1 of the clinical feature, where patient can have mostly the GI symptom, anorexia, nausea, vomiting, and malaise. Laboratory wise, there will be a mild electrolyte disturbances. Coming on to day 2 to 3, that is the stage 2 of the poisoning, where patient can have abdominal pain and hepatic tenderness, and GI symptoms may resolve, wherein in lab wise, you could see elevated transaminases, increase in bilirubin, and increase in PT. And between day 3 to 4 is considered as stage 3, wherein there could be recurrence of GI symptom and worsening of the hepatic toxicity, where patient can have encephalopathy and other organ dysfunction like anuria, where laboratory wise there will be worsening of the LFT. Along with that, there could be metabolic acidosis, coagulopathy, and pancreatitis. And more than 5 days, stage 4, where there could be clinical improvement or MOTS or death. So laboratory wise also, either there could be improvement in the laboratory or there could be worsening. Coming on to the biomarkers, one is the serum paracetamol concentration, where you have to mention this name of the nomogram. And if you draw the picture, that is when you will get the mark. So the x-axis shows the time from ingestion, and the y-axis shows the paracetamol blood concentration, where the level at 150 microgram per ml at 4 hours is considered to be the lower line, where the level at 300 microgram per ml at 4 hours is considered to be the high risk line. So if any patient lies on or above the treatment line, then they require NAC, N-acetyl cysteine treatment. If suppose the patient is on the high risk line, then there is increased risk of liver injury, where they may need increased dose of N-acetyl cysteine. Other biomarkers could be AST-ALT ratio and INR pH, lactate, and ALT paracetamol multiplication product. Coming on to management, so because it is specifically asked for paracetamol poisoning, if you concentrate more on definitive management is well and good, because this question has 2 subsections and it is only for 5 marks. So make sure you just mention the supportive management and write more on the definitive management. Decontamination with activated charcoal if patient presents within 2 hours of ingestion. And N-acetyl cysteine is the definitive treatment, and its mechanism, it replenishes the glutathione, it prevents the NAPQI binding to the hepatocytes, and there is a 21-hour regimen with loading dose of 150 mg per kg infused over 1 hour, with a second dose of 50 mg per kg over the next 4 hours, and the maintenance dose of 100 mg per kg over 16 hours. If the patient liver enzymes remain elevated and the features of hepatotoxicity are there, then you can continue the extended protocols with 6.25 mg per kg per hour. And if the patient remains refractory to the medical treatment, or if you think that the patient has a reversible cause and still can be helped like a younger patient, then referral to the liver transplantation is the next step. If suppose they fit into the King's College referral criteria with pH of less than 7.3, or if the INR is more than 6.5 with elevated creatinine and grade 3-4 of encephalopathy, or if lactate is more than 3.5 refractory to all the medical management, then refer them to liver transplant. And without transplant, the mortality as per studies remains high, more than 30%. But with transplant, the outcome and the survival rate is more than 70% at 5 years. So this completes our paracetamol poisoning. Coming on to the next section, that is question 8B, extracorporeal liver therapies. Where again the subtopics taken are like, what is the extracorporeal liver therapy, what are all the indications, and what are all the types available. Okay, so extracorporeal liver therapies are the therapies which could perform the essential liver functions via blood filtration and detoxification using an external device. So the blood is removed from the patient and passed through an external device for detoxification and then returned to the patient. Indications: whenever there is liver failure and the liver transplant is not immediately available, especially in patients with hemodynamically compromised states and in patients with hepatic encephalopathy, severe cerebral edema, and HRS not responding to the medical therapy, and uncommon causes of liver failure like cardiogenic shock, ACLF, post-partial hepatectomy failure, post-transplant graft failure. So what are all the types of ECLT available? Number one, artificial system. If you can just mention the name: Mars, Prometheus, SPAD, and HEPA-WASH. And bioartificial systems like HEPA-Assist and ELAT. And therapeutic plasma exchange is also one of the extracorporeal liver therapy to be mentioned. So just briefly about their mechanism and significance. So the artificial system, where the blood is passed through a dialysis filter alongside a current of exogenous albumin, the toxins are transferred to the albumin and then detoxified via the activated charcoal or ion exchange columns. So it uses a cell-free technique to detoxify the bloodstream. Coming on to the bioartificial system, the plasma is separated from the blood and run through a hollow fiber network containing the hepatocytes. So the only challenge here is the nutrition and the blood delivery to the hepatocytes to keep it alive for the entire process. So if you can see, just you can draw the simple diagram where blood entering through a filter with hepatocytes attached to the filter, and then it passes through. Then the third type is the therapeutic plasma exchange, where it removes the protein-bound and water-soluble toxins by replacing the plasma with the donor plasma or albumin solution. It is mainly effective for larger molecular toxins. It replenishes the synthetic plasma components. So coming on to complications for any extracorporeal therapy, hypotension because of the fluid shifts, hypoxia, hematological anemia, thrombocytopenia, coagulopathy, renal injury because of, again, the fluid shifts, toxin accumulation and HRS, electrolyte imbalances. Because of the line related, there could be sepsis, infection. So this completes our second question. And a part of question 10, that is part A, I'm dealing with. That is enteral nutrition in an hemodynamically unstable patient. So actually this question, when we were discussing, in an hemodynamically unstable patient, you have to just write what is the problem with that, right? But that may not get you the 5 mark, because it may carry, you may only write 2 to 3 lines regarding that. But if you go like a approach to an enteral nutrition in an ICU patient, in that if you incorporate the answer for hemodynamically unstable patient, then that will be a smart move for like the whole bunch of 5 marks, at least 4 to 5 marks. So here I had mentioned what is malnutrition in a critically ill patient with a pathophysiology. It may not be necessary, but what to write for the 5 mark, like what is the importance of the enteral nutrition was briefly discussed. If you skip this also, it's all right. But if you mention it, you may have a chance of getting the full mark. So that is what I told. Whenever you see a question, if you know what are the subsections you are going to write, even if there is no content to write much, which may get you the full mark, if you write in and around and with a subsection and a flow chart and a sensible diagram related to that, then you may get the at least the closer marks, like 4.5, like that. So coming on to enteral nutrition in hemodynamically unstable patient, I have just mentioned what is malnutrition and why enteral nutrition is important. So malnutrition is nothing but variation in the degree of nutrition with or without inflammation that may lead to variations in the body composition. In a critically ill, because there is release of inflammatory mediators, there is excessive catabolism and loss of lean body mass and malnutrition. And there is also stimulation of catabolic hormones, which may create energy substrates to support the vital organs. So when you give adequate nutrition, it may maintain the homeostasis, it may preserve the lean body mass, and may improve the nutritional states, which may overall reduce the length of the hospital stay, morbidity, and mortality. And especially enteral nutrition, they maintain the gut integrity and function, and they also preserve the immune function, gut associated as well as hepatic associated immune function. So coming on to approach to an enteral nutrition in a critically ill, hemodynamically unstable patient, for any enteral nutrition or nutrition, you have to start with nutritional assessment, where you have risk factors to see whether the patient goes into malnutrition or not. And you have some of these scores like Nutric score and nutritional risk screening scores. If you remember, please do write it as small tables. The second step is when to the timing of the nutrition. Generally, the enteral nutrition should be started within 24 to 48 hours of the ICU admission, if and when feasible. But in hemodynamically unstable patient, they may experience reduced peristalsis, gastrointestinal hypoperfusion, and chances of mesenteric ischemia, where the enteral nutrition may trigger intestinal ischemia. Especially when the patient is on high dose of vasopressors, then especially vasopressin, then the chances of gut ischemia is more. So in such a patient, the timing, the enteral nutrition should be started cautiously at a lower rate, especially once the patient stabilizes on declining doses of vasopressors. Avoid early enteral nutrition in a patient with bad hemodynamic instability like double vasopressors, high doses, and tropic feeds can be tried like 10 to 20 ml per hour to initiate with. Okay. So this covers both the approach to the enteral nutrition as well as the hemodynamically unstable patient, where your answer must have been only this. But if you write it as an approach, you may get a better score. Coming on to energy requirement again for an hemodynamically unstable patient, normally it is calculated using indirect calorimetry and validated equations to see the resting energy expenditure. And then the normal requirement is around 25 to 30 kilocal per kg, and protein is 1.3 to 1.5 gram protein per kg. But in acute phase of illness, you have to start with 20 to 25 kilocal per kg. In a recovery phase, you can slowly increase it up to 25 to 30 kilocal per kg. Okay. And coming on to micronutrient supplementation, selenium and some of the other important micronutrient supplementation may improve the outcome. And if suppose the patient is not meeting the caloric needs like 60% with enteral nutrition in the first week, then you may have to start with parenteral nutrition. Okay. So this is how you approach in an hemodynamically unstable patient for 5 marks. So this completes my question. If any doubts, please put it in the chat box. We'll respond to you. Okay.
Thank you, Bona.
Yeah.
Okay. I think so. Srihari's answered a few questions regarding the type of use of pens. So, for the benefit of doubt for the audience, by and large, so few questions were asked about whether it will be checked by us and will they be marked. It is really difficult for us to do that, but yeah, if you give us some time, we will be able to do if we have got the direct messages in the group. So for people who have given, probably we will try and do that. Okay. So we will see, but yeah, by and large, this was actually focused at a self-assessment type of an exam. Color pens depends. If the board says it's only black and blue, it's only black and blue. You can use pencils to highlight. So if you're using a blue pen, you can use a pencil or a black pen to highlight few things. So beyond this, colors, I don't think so. It will be allowed, but by and large, it's better to avoid using different colors. Okay. Srihari, are you around?
Yeah, I'm around. Is the screen visible?
Yes, Srihari, it's visible.
Okay. So, good evening to everyone again. Okay, so I'll go into my discussion directly. So, I'll be covering question number 1, 2, and part of question 3. So, regarding the first question, it was define ventilator associated events and management of carbapenem resistant Acinetobacter baumannii. Okay, so here under ventilator associated events, one thing I just wanted to say is here when you write about a question, it's just better to give a small gist of what are the topics for discussion, because contents you may know, you may not know, but at least if you have the topics for discussion, it may give an impression to the examiner. Okay, you have an idea related to that. So even if you give little inputs, you may get some mark. So that would help in a way. So for ventilator associated events, it's mainly the definitions that you need to be well versed with. So coming to the introduction part of it, you can just mention it like ventilator associated events is basically a surveillance definition that was developed by CDC. Now, the important thing is the DrNB exams,
specifically mentioned no short forms. So what you can do is, because you will have so many questions and so much to write, writing it in short forms, writing it in full words, it will be really difficult. So what I actually did and what my colleagues also did were, you write it in full form and then put it in bracket in the short form. So then you can subsequently you can use those short forms so that the examiner knows that this short form means this. So that would be beneficial for you also and for the examiner also, so that there will not be any marks that will be deducted based on this issue. So just for an introduction related to ventilator associated events, just a 1 to 2 lines you can just write, saying that it is just like a definition that was created to create an objective and streamlined criteria for identifying complications occurring in a mechanically ventilated adult patient. So with regard to VE definition, they say a patient has a baseline period of stability or improvement on the ventilator by 2 or more calendar days of stable or decreasing daily minimum FiO2 or PEEP values, followed by worsening oxygenation. So since FiO2 and PEEP are again in short forms, I've just written it in bracket so that there are no issues that you will face subsequently when during correction. So under ventilator associated event, there are 3 areas that you need to concentrate. One is ventilator associated condition, infection related ventilator associated condition, and VAP. So I had read one answer paper where they had only mentioned about the ventilator associated event, but they are not emphasized on this. So if these 3 definitions are not there, then you won't get the marks. So regarding ventilator associated condition, it is 2 or more days of stable or decreasing daily minimum FiO2 PEEP, followed by an increase in daily minimum PEEP, daily minimum FiO2 more than 0.2 over the daily minimum, or an increase in the minimum PEEP more than 3 centimeters of water. So whichever area you feel is important, you can emphasize it by just underlying it, or you can use a different ink at that time if time permits. So once you do that, you can just make it like a flow chart so that you can save space and you can save time. And you don't need to have to write fully detailed sentences. So you can just write it like you can just write the content which you need is necessary in a legible format so that the examiner will understand. So after ventilator associated condition, the next spectrum will be infection related ventilator associated condition. So that is ventilator associated condition. See, I put it in a bracket in short form. So I just added here and then added on the other criteria that is needed. That is temperature differences and either leukocytosis or leukopenia. And along with that, a new antimicrobial agent is started and continued for 4 consecutive days. So that they mention it as also called as qualifying antimicrobial days. So if you are able to compress it like this, there are 2 advantages. Thing is, they are only providing you 5 pages for each question. So if you are able to make it more legible and more clear in this format, one, you save space and you can write more contents. Because if you see here, ventilator associated pneumonia has 3 criteria. So you need to fit in all the 3 criteria within this 1 page. So if you are able to compress on the other areas, then you can save space for the areas which you need more elaboration. In that way, it will be very helpful. So for ventilator associated pneumonia, it is infection associated ventilator associated condition plus one of the 3 criteria. So this is very important that needs to be mentioned. So you can make it in small paragraphs, or you can make it like in flowchart formats like this. But when it's in paragraph, it should not be too lengthy. It should not contain too much of gibberish content. It should be to the point. That's how you are going to get marks. So here you have 3 criteria. One criteria is without purulent respiratory secretion. So you have an endotracheal aspirate 10 power 5, BAL 10 power 4, and protective specimen brushing that is 10 power 3. And here everywhere I've mentioned CFU. So on the bottom, you can just put CFU and put a dash and mention colony forming units. So the examiner is aware, okay, what that short form means. because there may be times where some short forms will have multiple meanings. So that may cause confusion. Then you have a second criteria that is based on purulent respiratory secretions. That is, definition is more than 25 neutrophils and less than 10 epithelial cells per per low power field. And the organisms identified from one of the specimens don't have the sufficient growth criteria from criterion 1. So that will be under criteria 2. And criteria 3 is one of the tests isolated from either pleural fluid or lung histopathology, or based on immunohistology, chemical assays or cytology, it has been identified, or diagnostic testing for Legionella, influenza, COVID-19, and parainfluenza. So if these three are mentioned itself, you like VAC, IVAC, and VAP are mentioned along with VAE introduction, I think that will fetch you a good amount of marks. So once you finish all this, in the last part, if there is positive cultures or a Gram-stain positivity, then it is a possible VAP. If both are present, it is a probable VAP. So that is just for the completion of it. So the thing is, each question should be allotted a certain period of time. So your exam is for 3 hours, that is around 180 minutes. So each question you will get around 18 minutes. But the important thing is you don't give full 18 minutes for one question. You give it at least 3 minutes less, that is around 15 minutes, so that the last 3 minutes can be saved towards the end. So for every question, if you just take around 15 minutes, at the end you will have 30 minutes. So once you've completed all the questions, then you can come back to the areas where you have not completed and then fill it out so that you don't miss any question. Because the specific thing that they say in DrNB exams is you don't skip any question, because if you write something, at least you will get at least 2 to 3 marks. So that will help you in your final score. So that is very important. And towards the end, last 5 minutes, you save it for the revisions. So over here, if you're able to finish all of this within 15 minutes, well and good. If you're not, whatever you have filled it within this 15 minutes, you leave it and then you go for the next question. So this is about ventilator associated event. So you need to mention about a basic about ventilator associated event, VAC, IVAC, and VAP. So next is about management of CRAB. So I just mentioned it under 2 headings. One is under the issues and the other is the treatment. So issue is like you can mention it as 3 forms. It is very like most of it is recovered from respiratory secretions or wound, and it is often difficult to identify because it can be an isolate or because the isolate can be either a colonizer or a pathogen. So leading to uncertainty related for the need for antimicrobial therapy. So once Asneto exhibits carbapenem resistance, only few therapy options are there. And crab isolates also produce metallo-beta-lactamases and serine carbamases, limiting utility of carbapenem agents. So if you write these in short sentences, the examiner will have an idea, at least you have a basic knowledge of this. So coming to the treatment, you can mention from where you have taken your source. So if you mention this IDSA 2024, then that will give an idea that, okay, fine, he knows this, or he or she knows this guidelines. So, and that will favor better marking. So 2024 guidelines now recommend a sulbactam containing agent and combination therapy with at least 2 agents wherever possible. So one thing I wanted to emphasize is whenever you get an infectious disease related question, that is like especially related to multi-drug resistance, like this question, always make a point to mention about the infection control practice that needs to be followed, and then the specific treatment management. So usually if it is CRAB or CRE or like in these conditions, you need to go with contact isolation. So that is must. So I just mentioned it in short term so that the examiner is aware of it. And then for the treatment of CRAB, you can classify it into mild or moderate to severe. So for mild, mind you, 2024 specifically says you have to go with sulbactam and durlobactam combination. Then along with that, you need to add a carbapenem. Either it can be imipenem, cilastin, or meropenem. So this was not there in the previous guideline. This drug had come only in 2023. So in 2024 guidelines that I've mentioned, this is now considered as the preferred agent. So then in the alternate therapy, you can consider ampicillin sulbactam, where a total of 9 grams per day of sulbactam has to be given. So then along with other alternatives that can be considered are polymyxin as monotherapy or high dose tigecycline that needs to be as combination. So in this itself, you can mention medications that are not recommended. So you can mention about fosfomycin, rifamycin, and nebulized antibiotics. So one of the papers I read, they mentioned about this. That was very good. So then coming to the moderate to severe disease, you need to go with combination therapy. So minimum of 2 drug combinations should be there. So here's, since they have told sulbactam, durlobactam is the drug of choice, you can mention it here also. And along with that, in the alternative therapy, you can add in this format. That is ampisulbactam plus polymyxin B or tetracycline derivatives like tigecycline, minocycline or ravacycline or cefiridocol. And you can give a small idea, like a small, like one-liner related to that, like only limited to cases where there is resistance to all other agents. You don't have to write in depth about each antibiotic because you won't have much time for that. So the dosing and the regimen that is followed, I think that would suffice. If you have time, then you can mention small related like issues like how does it act? Like, what is its benefit? Like sulbactam, they say it acts on the penicillin binding proteins and inhibits the activity of all these beta lactamases. So that can be added at that time, provided you have time. But the main gist of the content should be there. So this is related to the first question. So the second question was myocardial infarction definition and types, and then there was a case scenario. So coming to myocardial infarction, so that was pretty straightforward. So they had asked definition and types. So once you put the definition, you can mention the source where you have taken it, like ESC 2023. So here you can just mention it like a one-liner, defined as myocyte necrosis in the clinical setting of acute myocardial ischemia. So how do they look into it? One is symptoms of myocardial ischemia, where you can mention it like chest pain, diaphoresis, and evidence of myocardial injury. That is definitely defined by elevation of cardiac troponins. So whichever area you feel is important and you want to highlight it, you can make it like straight line or you can make it like a design ledge. So that will make it more that will emphasize what you want to say to the examiner with at least one value above the 99th percentile of the upper reference limit. And along with this basic definition, you need to mention what is NSTEMI and STEMI. So I think that is pretty straightforward that you would already know about it. So these content should be there in your definition. So then coming to the types of MI, this I think relatively everyone had answered about it, but just to emphasize on type 4, there were only 2 that was mentioned, type 4A and 4B. There is a 4C also, which you need to know, that is restenosis without thrombosis. So that also needs to be kept in mind. So what I would emphasize is if the question mark weightage is low, keep the number of pages for that question on the lesser side. So that for the high mark question, that is like if this question had types of MI and definition for 3 marks, and the subsequent question was for 7 marks. So try to finish the first part of the question for as many less pages as possible so that you can save more content for the second part question. So the second part question was more related to a tachyarrhythmias. So it was a 74-year-old diabetic hypertension, IHD with heart failure. They had come with chest discomfort, diaphoresis, restlessness. ECG showed narrow complex tachycardia with a BP of 160. So they had asked about the approach to management. So this you can go it in 2 ways. One is about how you identify whether it is a regular or an irregular, because they are not mentioned about the rhythm, whether it is regular or irregular. So you can mention about that. So if it is irregular, yes, it's pretty straightforward. AFib can be there, A flutter can be there with multifocal AV block or multifocal atrial tachycardia. Then if it is regular, you see if it is P wave visible or P wave invisible. If P wave is invisible, then it is AV nodal re-entrant tachycardia. And if it is visible, then you assess the P is to QRS. If there are more P, then it is an atrial flutter. If P and QRS are equal, you see the RP interval. If it is short, it is an AV and RT. If it is long, it is sinus tachy or an atrial tachycardia. So once you put the basic algorithm for identifying a regular and irregular, then you come to the general management. So general management is purely our AHA algorithm based. So I've just taken mainly from that only. So you mention it like the heart rate more than 150, then identify and treat the underlying cause. So maintain patient airway and assess breathing as necessary. Oxygen if hypoxic, monitor BP, IV access, and 12 lead ECG. Whatever is there in that is what I have put in this. And if there is persistent tachyarrhythmia causing hypotension, altered mental status, chest pain, signs of shock, and acute heart failure. So our patient that like the patient that was discussed in the case had two of these features, so that you can mention it so that it will add more value. So if these features are there, you go with synchronized cardioversion. They say consider sedation. Usually we give it as like midazolam, so that you can add. And then airway equipments kept as standby, then dosing. So this is very important. So for narrow regular, it is 50 to 100, and narrow irregular 120 to 200. So these details should be mentioned clearly. And if it is AV and RT, adenosine can be tried. First dose of 6 milligrams and second dose 12 milligrams. So if you write it in this flowchart manner, then it will save space. Plus, it will make it very clear to the examiner that you know what you are writing and what you like about your knowledge regarding arrhythmias. So if it is refractory, then they say consider the underlying cause. Then you need to increase energy level for the next cardioversion, addition of antiarrhythmic drugs, and expert consultation. So this is just purely from AHA. So underlying cause alone, it was not mentioned in that, but usually for any tachycardias that are present, you go with etiologies. For the easiest way to remember, you go with 5 H's and 5 T's and pain, agitation, and delirium. So if you go in this manner, you will not forget anything, and it will be very spontaneous when you write your answers. So once stability is attained, then you go with pharmacological agents so that you can mention it like this. And then you can just mention the list of drugs like IV metoprolol initially, and then you can change it over to oral metoprolol, ivabradine, diltiazem, ivabradine and amiodarone. So since our case, like they've given the scenario, like patient had heart failure with reduced ejection fraction, the other drugs like diltiazem, verapamil, flecainide, propofenone, ibutylide, vernaculant are contraindicated in this case, so that you can mention it like this. The important thing is when you're mentioning a drug, you need to mention about the dose. And if it is an infusion, the infusion rate that needs to be kept. So that needs to be very clearly kept in mind. So along with the basic AHA management, if it is an atrial fibrillation, you will also need to mention about anticoagulation. So in the exam stress, we usually forget about it, but it's very, very important because if an AFib is there, along with pharmacological therapy, you need to consider anticoagulation. So mainly to avoid stroke. So you can mention it as per the Chadwas score, and then you could mention the criteria like a score of maximum score is 9. If it is 2 or more in males or 3 or more in females, oral anticoagulation is recommended. So then you can just mention the drugs quite which you can use like dabigatran, rivaroxaban, apixaban, and rivaroxaban. So once along with this, you need to also mention about the bleeding risk assessment, that is the Haas blood score. So along with that, you can mention in a score at which point, what is the significance. So if it is less than 3, then you need to follow up every 4 to 6 months. And if it is more than 3, then it should be followed up. Patient should be followed up every 4 weeks. So if you go about this, think that will fetch you a good amount of marks. Thing is, if you have time and you have more ideas that are related to this arrhythmias, then you can add it on. This is like whatever I've mentioned over here is not like the final and valid component. Like there are other points that can also be added, but these are the minimum things that you need to be aware of when you write this question. So this is related to question number 2. So the next question that is related to question 3, it is a 2-part question. So that is management of acute ischemic stroke with evidences. Now, one thing I would want to say is paper 2 will be related to critical care management. So 10 questions will be more of management related cases, and invariably every case will be very much will have a lot of content to write. So you need to be very clear on your spacing and your content which you need to write, because if you keep writing too much for one question, then you will compromise on the other questions. So timing is very, very important when you write about management related questions, because management of acute ischemic stroke by itself has so much to be written about. So how I had written it is the first part, the initial management. So that's how I put like the first part, and then the second and third part that I'll be mentioning subsequently. So in the first part, once the patient enters the emergency room with stroke, you do the stroke assessment based on the NIHS scale. That is the National Institute of Health Stroke Scale. So if you mention it in short form, because subsequently again there are certain criteria based on the NIHS. So I mentioned it as I mentioned the full form over here. So along with that, you need to know about the timing. So that I've mentioned it here itself. Door to physician less than 10 minutes and door to stroke team less than 15 minutes. And it is important to inquire about the stroke's onset, that is the history. And then is about the airway, breathing and circulation. Then you come to the diagnostics. So here you can mention about the initial blood tests and imaging, that all will come over here. And here you can mention about a smaller part about the stroke mimics, that's the differentials. I think in the exam, I think 4 to 5 differentials will do, because you won't have time to write too many differentials also. So just to keep like to make sure that you have not missed anything. Then after that, you go with the door to CT interpretation, door to drug, and then door to stroke unit admission. So once you mentioned all this, then you can mention about the indications for ICU. So that will be all these 5 will be that. There is need for intubation, ventilation, patient had presented with a generalized clonic seizures, patient had a very severe stroke based on the NHS score, or very labile BP, or the patient has come into the ICU post decompression craniectomy. So if you mention this, it gives an idea that you know about how to approach initially when a patient arrives with stroke, ischemic stroke. And along with the CT, in this door to CT initiation, you can mention about non-contrast CT. Why do you do it? So 2 reasons are there. One is to rule out intracerebral bleed, and other is to assess the aspect score. So like I said, just a small word about the full form also should be mentioned, and the main reason for it, that is to classify severity and the outcome. And if it is more like a wake up stroke, then you need to mention about MRI brain and this like the criteria what they give. So I mentioned it in very, very simplified manner, just to keep and like show that this is also one of the modalities that can be used initially. Then after the initial part, then you have a general management. So you can classify based on various systems, or you can go with the fast track approach. So initial part is for the respiratory. If it is self-ventilating, you do continuous pulse oximetry to maintain a saturation of more than 94. If it is intubated, regular ABGs to maintain a PO2 of 80 and PSC2 of 35 to 45. Then you have BP management. That is, if at all thrombolysis is being done, what are the targets that needs to be done and how frequent the monitoring needs to be done. And the BP targets in a thrombolyzed and a not thrombolyzed patients. So if it is mentioned like this, then I think that will save space also if it is more concise. Then cardiac, that is continuous ECG monitoring, fluid, individualized fluid management, 0.9% normal saline is recommended in guidelines, that can be mentioned. Then glucose management, temperature management, that is avoid temperatures more than 37.5. So if you mention all these basics, and along with that, if you you add on fast track bit, if it like also, that will definitely give a good impression. Then you have specific management, that is revascularization therapy. So like I said, this question is very elaborate. It's a five mark question, and it is a it is a 2-part question. That is 3A was related to acute ischemic stroke, and 3B was multimodal anesthesia. So within within 3 pages, you need to complete all your management. So you need to cramp up as much as data as possible in a very refined manner. So that you need to practice. So here, revascularization therapy, I've mentioned about IV thrombolysis and endovascular therapy. So IV thrombolysis, I mentioned about the timelines. So 0 to 3 hours associated with good clinical outcomes. The evidence was the NINS trial. Then 3 to 4.5 benefit was there, but with increased risk of bleed. That is the ECAS 3 trial. So the contraindications that were there in this subset, I have mentioned over here. And if it is 4.5 to 6 hours, IV thrombolysis failed to play a role. So that was based on the ECAS 1 and 2 and Atlantis trials. So if you mention this, that will also add more value. And here, the drugs that can be used, that is RT-plus. So the dosing I've mentioned, and tenecteplase also can be used. That was based on the Extend 1A TNK trial. They've shown it was inferior to RT-plus. So that I've mentioned over here. So this is almost like a real time scenario. Thing is, when I was writing it very fast to cover it within 15 minutes, I had actually not written this place part properly. So this is one error that you should always, there's one thing that you should always look into, make your words very legible. Because towards the end of your paper, your handwriting will go very haywire. So make sure at least whatever words you're writing is clear so that the examiner will know what is the contents that related to that question. So then you can just, if since there was space over here, I mentioned about the contraindications also. That is absolute and relative. I think 4 to 5 contraindications for absolute and relative can be mentioned. So then in the next page, I mentioned about the endovascular therapy. That is intraarterial therapy, intraarterial thrombolysis and about mechanical thrombectomy. The timeline where mechanical thrombectomy is shown to be favorable, associated with favorable outcomes. So the associated trials also I have mentioned, Dawn, Diffuse 3, Revascat, and Mr. Clean trial. So on what criteria they have taken it is, I've just mentioned 4 of this because for Dawn and Diffuse 3, there are around 6 to 7 criteria. So it's difficult to fill all of that within this space. So at least things that are common to both of it alone, if you mention over here, I think that would be sufficient. So that's why I mentioned about 4 important things that are very common to both of them. And then after that, I mentioned about malignant stroke. So the criteria for malignant stroke, here I mentioned about 4 criteria. That is MC territory stroke more than 50% on CT, perfusion deficit more than 60% on CT perfusion study, infarct volume more than 82 ml within 6 hours of onset, that is on MRI, and more than 145 ml within 14 hours of onset on MRI. These numbers need to be memorized. So treatment is decompression craniectomy. The benefit is it decreases intracranial pressure and it improves the perfusion of the penumbra. So it is associated with good survival but poor functional outcomes. So the trials related to that were the Decimal, Hamlet, and the Destiny 2 trial. So the important thing that I wanted to emphasize my answer was I wanted to say all the primary outcomes were based on the modified Rankin scale. So I just put it in a box. And the other aspects of management, antiplatelet therapy, anticoagulation, and seizures. Important thing, there is no prophylactic role. If clinically present, anti-seizure drugs can be initiated, either phosphonatoin or levetiracetam. So if you have time, you can mention about the doses also along with that. So believe in yourself and you will be unstoppable. Definitely, it's a high stress time right now, but you guys will definitely clear through. So all the best.
Thank you, Srihari. Well said, actually. So that's
Okay.
the thing, guys. Actually, most of the times the paper would be set better than what we have given. Whatever paper we set was quite difficult and quite lengthy. So if you guys have written this paper, I think so you can write any other paper. The point was to make sure that you guys understand that it will be quite at length. This particular question that Srihari discussed in the end, that is acute ischemic stroke, usually if we write with evidence, will by and large be a 10 marker itself. So there, coming down to 5 marks is a little, difficult. So if you have written roughly around 60% of whatever Srihari said, I think so you would get full marks. So without wasting much time, I'll go to the next question. Is my screen visible?
Yeah, that's it.
Okay. Okay. So the questions I'll be discussing is, firstly, I'll start with this particular question, that is the declaration of brain death. And the part B of the question is the ethical principles of end of life care with example. So by and large, this is what you should write. Okay, just make sure that you have this particular flowchart in mind. Okay, because it's given for a 6 marker question. To explain each detail would be difficult, but if you have written it in a particular order, like say, suppose you started like writing the etiology establishment, then you do the neuro assessment, apnea testing, and declaration of brain death. If you have gone in these particular headings, probably you will get full marks. That is your 6 marks. So what I individually mean by each thing, I'll be talking to you in the next couple of pages. Okay, so when we talk about establishment of etiology, definitely we have to rule out the irreversibility of coma. You have to rule out the confounder, presence of drugs or toxins, and along with that, you should have prerequisites that have to be met. That is, your systolic blood pressure should be more than 100 millimeters of mercury, your MAP more than 60 millimeters of mercury, your PaO2 being more than 100, and PCO2, as much as possible, try and keep it in the normal range, that is between 35 and 45. If you have your reversible etiology established, if you have your prerequisite met, then you can go for neuro assessment. In neuro assessment, you have the irreversible coma, then you go ahead with doing the brainstem reflexes, wherein you just try and evaluate the cranial nerves. So you will be starting off with pupillary reflexes, then you will go and do the oculocephalic, that is your doll's eye, as well as your oculovestibular reflex, your gags reflex, cough reflex, and you have to also look at the motor function by and large. Once these are established and there is no brainstem activity, okay, then you have to go ahead with the apnea testing. In India, it is THOTA, that is the Transplantation of the Human Organs and Tissue Act. That is what we do. So brain death is usually defined after the second apnea test, which is done at a span of 6 hours after the first test. So you have to talk about that. Test one and then test two. How do you do it? That is something that you have to give in a brief. And then if it is inadequate, either of them, probably you have to use the ancillary tests. Okay, then after doing all of this, you can go for declaration of brain death, in which you might have to tell who is supposed to do it. If you have this outline for the answer on declaration of brain death, you will be able to get marks. You can start by writing this flow chart, and then you time your answer. You have roughly around 10 to 15 minutes per answer in your 10 marker, right? So based on that, if you write this, you'll be able to answer it accordingly. So if you feel that the time is short, you can write how much ever is possible and come back to this in your revision time. Okay, then you write the remaining half. Okay, so whenever we talk about declaration of brain death, then you have to start by definition. That is irreversible cessation of all functions of the brainstem, include brain and the brainstem. The most important thing is it is characterized by an unresponsive state with absent reflexes and spontaneous breathing efforts. Usually you have to know the etiology. If you have mentioned the etiology, well and good. If not, you can just avoid it. If it's a 10 marker per se, like how we thought about acute ischemic stroke, you can go under the following headings. Okay, so how will you have uh, the etiology? You can either classify based on traumatic or non-traumatic, and based on that you can write in the etiology which is causing brain death. Prerequisites, write it under these probable headings, that is establishment of cause, baseline conditions, and clinical testing and documentation. And you also, it's better if you have time to write about brain death mimics, because this is what you are thinking about, ruling out the reversible causes, right? So in that cases, what are the reversible causes? Probably it might be hypothermia, locked-in syndrome, high cervical cord injury, botulism, or the presence of drugs and toxins. So this is something that you need to mention. Along with this, right, that confounders, whenever they're present, especially if they are drugs, usually a 5t half time should have elapsed before even you can go into the assessment of brain death declaration. Hypothermia should not be there. Excessive hypotension should not be there. Usually this hemodynamic instability, if there's inotropes which are present, they have to be optimized. Remember the rule of 100 that we have mentioned earlier in the classes. Also rule out the presence of any metabolic causes like hypoglycemia. Okay, so if these are there and these things are ruled out, so you can be sure that the confounders for brain death is ruled out. Okay, so after that, the next thing is clinical testing and documentation. Usually whenever there is an anoxic brain injury, the period of time which is supposed to be there is roughly around 24 hours. For spontaneous intracranial bleed, it is roughly 6 hours. Head injury, After a traumatic brain injury, 6 hours, and major trauma, neurosurgery, aneurysm, roughly around 4 hours. Okay, so this is something that you can write if you have time. Otherwise, you can omit it. Testing very much important. Whatever tests you do, especially your brainstem reflexes, your cranial nerve examination, mention the afferent and efferent. Okay, so all of this you have to look into it, read again and write it. And very importantly, prerequisites for testing it, that should be present. Whenever you're thinking of all of this, make sure that there is no c-spine injury, make sure there is no CSF autoria. Okay, because if at all any of this is present, that can be detrimental, and it is not right to do it. Okay, you might cause more harm for such patients. Okay, so whenever you're writing, please make sure that you write the afferent and the efferent. So pupillary, afferent is 2 and efferent is 3. Oculocephalic, your Doyle's eye should be negative. Okay, your afferent is the 8th cranial nerve, and the efferent is 3, 4, and 6 cranial nerve. Oculovestibular, as the name goes, it's cranial nerve 8 is the efferent is cranial nerve 3 and 6. Okay. Cough reflex, gag reflex, you know very well. Okay, that is the 9th and the 10th cranial nerve being afferent and efferent respectively. Apnea testing, it is the most essential part of declaration of brain death. Okay, so make sure that you do apnea testing after you have removed all the confounders and you have optimized the patient. Okay, be it with respect to carbon dioxide retention, or hemodynamic instability requiring inotropic supports, etc. Okay, so usually you can write it in a stepwise fashion. Pre-oxygenation, then draw in an ABG, uh, continue insufflation method or a CPAP method for the apnea testing for a period of 10 minutes. Withdraw apnea testing if there is worsening of hemodynamics, and then do an ABG after a span of 10 minutes. Okay, if you have done this, this usually should involve your clinical testing and documentation. Then it will come to interpretation of apnea testing. You know very well, if there is a 20 millimeter rise after 10 minutes from the baseline, that is indicative of brain death. Or else, roughly they say anything more than 3 mm of Hg per minute increase in PeCO2 level is an indicator of worsening brain activity, that is your brainstem death. Okay, this, after doing the first apnea test, you have to do a second apnea test after 6 hours, and then at that particular time you can declare the patient as brain dead. Okay, usually if one of these tests are not okay, the law in India is still not clear, we are still dependent on apnea tests, but elsewhere the use of ancillary tests for the declaration of brain death is acceptable. What do you usually do? You do a DSA to see the reversal of flow. You can do cerebral angiography, EEG, SEP, okay, one SSEP, etc. Okay, so you can just name the test. That's more than enough. Okay, if you have given what are the testing. But if they specifically ask what is this particular test, then you might have to elaborate on that. Okay, so you please read up about these things as well. Okay, then comes to the certification, because your question was declaration of brain death, so you should also involve this, who is the person who is involved in declaration. So usually it should involve the treating doctor. Along with that, usually there will be a nominated doctor as per the act. So it can either be a physician, intensivist, anesthetist, but definitely it must consist of a person with neurology background, either a neurologist or a neurosurgeon. Okay, along with this, you should be remembering that this patient should not, this doctor should not be directly involved with the transplant team. Okay, so two doctors must be present at the time of assessment. They both have to agree to each person's assessment, and only then they can declare brain death. So remember, start with ruling out confounders, prerequisites, neuro assessment, that is irreversibility of coma followed by brainstem reflexes and cranial nerve examination, apnea testing, test 1, ABG, before discontinuation from the ventilator, document the PaCO2 level. 10 minutes later, again look at the CO2 level more than 20, then probably brain death. Repeat the same test after 6 hours. Test 2 is also similar to test 1, then you can declare brain death. If anything is inadequate, use ancillary tests. And after that, two doctors who have been certified, one is a treating doctor, other one needs to be a neurologist or a neurosurgeon. Okay, so based on these two people, you can go ahead and declare the brain death. Okay, so this is by and large about the declaration of brain death. So part B of the question was, what are the ethical principles of end of life care? This is a very easy question. Okay, usually they will club like this. Okay, if the part A is very lengthy, the part B will be very small. Okay, so all of you know, they are usually called the four pillars, but right now, if you see the palliative care, principles, they have added two or one more extra, that is dignity, autonomy, beneficence, non-maleficence, social justice, and dignity. So you can write whatever example seems fit to you. Just remember that, okay, whenever you're reading that particular thing, remember your example. That's more than enough. It need not be the same thing that I'm mentioning here. Autonomy, you know very well, it's the patient's right to make decisions regarding his or her life. It is still legal in India as well, regarding refusal of treatment. Say suppose a patient has carcinoma, CKD, they are having the autonomy to say that I do not want dialysis, I do not want to take chemotherapy. Okay, that is the part of ethical principles, owing to autonomy. Beneficence, you should remember, this is something which actually deals with the doctor who's treating. Okay, so this is something that the patient, it is the act to do something in the best interest of the patient. Okay, especially it is aimed at enhancing the recovery or improving the recovery at that particular time, or very minimal, like to improve the quality of life. Okay, so for example, sometimes for beneficence, what you need to understand is the doctrine of double effect. So, you give pain management for a certain group of patients with cancer. At that particular time, questions like the family might ask, yeah, put the patient to sleep? Can the patient become unconscious? Yes, it's not an intended effect, but yes, it is something that we are looking at the broader picture. Correct. So the main aim or the thought of the doctor was the benefit. That is, patient is in intractable pain, and you are starting a painkiller. So that is about beneficence. Non-maleficence, again, it involves the doctor. It is to avoid, as and when possible, any treatment or procedure which can actually prolong a suffering. Okay, rather than helping the patient. At times it can even worsen or harm the patient. Example, if the patient is in terminal illness, has come to the ICU with metastatic cancer in a very poor state, and he's dropped his GCS probably because of CO2 retention, CA lung is the thing. At that particular time, intubating this patient would be futile because you're prolonging life unnecessarily. So, such things like withholding is something which is acceptable. It is not maleficence. That is, you're doing it with the benefit of the patient at mind. That is why it is coming under the principle of non maleficence. Okay. That's the social justice, which we all knew. Take an example of COVID itself. Okay, you know that any patient who was young, without any comorbidities, at time when beds were really very scarce to get, especially ventilator beds, we usually took patients of younger age group. Wherein possible, if their patients are elderly with multiple comorbidities, especially with CA and all, if at all there was a crunch, we would choose the younger population. Similarly, whenever we are providing care, we usually not don't see anything about the economic or a financial background. We just do the best possible for all patients. So you can give examples like that. Okay, so dignity is one thing which they have added quite recently. Okay, so in that patient, you have to remember, whenever you're treating a patient with terminal illness, or for that matter any patient in the ICU, you should remember that the dignity or the self-respect of that patient is maintained. So like personal hygiene, etc., has to be addressed. Okay, probably the patient is unable to communicate for any reason, but at that particular time his likes and dislikes should not be neglected. Okay, his personal hygiene, his nursing care should be in par, if not less, as compared to any other patient in the ICU. Okay, so by that they should feel that they're not being neglected because of their illness. Okay, these are the things about your ethical principles of end of life care. Okay, so remember, it's a very lengthy question again. If you write it in certain headings, if you fill up your answers based on the headings and come back later on if there is a crunch of time, it is okay. So this is something that I just put in because, please excuse me if my handwriting was not good, but yeah, this is something that you need to do. Okay, stabilization and evaluation of a comatose patient, then probably rule in the reversible causes either by examination or imaging. Then you do the brainstem reflexes, apnea testing, and then probably go ahead and declare brain death. Okay, Sometimes you see motor responses which might not be compatible with the normal brain function, okay, like your Lazarus reflex, etc. Okay, sometimes you can see facial twitches, finger twitches, which the family might say, yeah, the patient is having some action, right? So these are some motor responses which are seen, but it's okay. Okay, you can just look at these things and tell them that this is not uh, incompatible. This is incompatible with normal brain function. Okay, this is something that you can tell the family. Again, remember your root values for your brainstem reflexes. Okay, from starting from the eye, going on to the prerequisite while doing your dorsal. Make sure there is no C spine injury. Okay, and there is no CSF photoria or any damage to the tympanic membrane when you're doing any calorie testing, etc. Okay. So ancillary test, remember your four vessel cerebral angiography, radionuclide scan, and a CT angiography. Okay, so the gold standard is a four vessel cerebral angiography where it shows the reversal of flow. Okay, so just remember that. Next question is quite straightforward, I think. So this is the question that most of you would have answered easily. Expanded dengue, warning signs of dengue, and diagnosis and management of HLH, which might be a probability that it is a worsening case of a severe inflammatory condition. Okay, so most of you might have written the right answer. Okay, so expanded dengue is nothing but it is an atypical or unusual manifestation of dengue fever that extends beyond the classic febrile illness with thrombocytopenia. Okay, so if you have written the words like atypical, unusual manifestation, which is not defined as per the WHO criteria, one of these words if you have written, 1 mark you will get. The second mark you will get when you write what are the components of expanded dengue. That is something like multi-organ dysfunction, which is usually immune-mediated mechanism. That is either acute kidney injury, encephalitis, myocarditis, rhabdomyolysis, or acute liver failure. If you have written these two things, you will get your full marks. Okay. So coming to the second part of the question, that is warning signs of dengue. Usually, this is just telling that uh, basically they look at the face what it is. If you've written that it usually happens in the second inflammatory phase of dengue, that is good. Okay, it actually follows the febrile phase. After the febrile phase, patient can show signs of warning. Okay, wherein you will see that the hematocrit goes up, there is a sudden drop in platelet count, right? That is the graph that you see. So it is usually the signs which are seen are severe abdominal pain, usually associated with vomiting, dull aching, and a persistent type of pain. Vomiting, usually it will be increase in frequency and associated with this electrolytemia and acidosis. You can write about mucosal bleed that usually happens because of coagulopathy and worsening thrombocytopenia. Restlessness and lethargy, that is usually due to a worsening shock state. Okay, it can be either due to pure perfusion or sometimes due to dyselectrolytemia. In worst case scenario, it can also be due to acute kidney injury, and that is secondary to rhabdomyolysis. Hepatomegaly, transaminitis, capillary leak, all of this is also associated with warning signs, which is seen in severe dengue or dengue hemorrhagic fever and dengue shock syndrome. Okay, so these are the things that are warning signs. Okay, when you're mentioning about this, you can either write it in this format wherein each symptom is mentioned and what are the associated things, or you can just write the names and then you can actually mention as the lab parameters and symptoms. Okay, lab parameters like your hematocrit going up suddenly, a platelet count dropping below 20,000. Okay, so those are also showing signs of warning signs of dengue at that particular time. Okay, so you can also mention your liver span. Okay, hepatomegaly, usually if you see a liver span of more than 2 centimeters below coastal margin, that is also considered to be an early warning sign for severe dengue. Okay, so you can write it this way or anything else that you guys feel like writing, that's also acceptable, but write it under these things. Okay, so if you have by and large written this, you would have definitely got roughly 3.5 out of 5. So if everything is written, definitely you will get full. Okay, but yeah, usually they tend to give a little less. Okay, so they won't give full 5 out of 5, probably 4 if you write everything. Okay, so coming to the part C of the question, that is diagnosis and management of HLH, that is your hemophagocytic lymphohistiocytosis or macrophage activation syndrome. Okay, so you guys should know there is a differentiation. Okay, so usually If the thing was asked as diagnosis and management, you just have to write diagnosis and management. You can omit the first thing, that is your types and causes. I've just written it so that you guys have a look at it when we are discussing. You all know there is a primary familial, secondary which is acquired, and secondary, when I'm talking about, it can be associated with rheumatological causes, usually which is defined as macrophage activation syndrome, or it can be associated with malignancy like HLHM. Treatment associated HLH, usually associated with chemotherapy and immunomodulation. Sepsis associated HLH, like in cases of dengue that we actually spoke about in the previous two questions. Okay, and sometimes it can also be secondary to immunocompromised state. Okay, if they've not asked types and causes, omit this totally. Okay, no need to write it. Okay, usually if you're writing it, start off by telling that HLH is a rare fatal disorder that can occur due to dysregulated immune response to inflammation. If you write this and underline the thing that it is the dysregulated immune response, that gives a fair idea to the examiner that you know what HLH is. Okay, and then if you write the diagnostic approach, like I've mentioned below, that should be enough. Okay, usually it should help the trigger bell should ring when we have a patient who is febrile. Okay, persistent high grade fever is present. You see that there is a cell lineage drop, either it is by cytopenia, sometimes all the three cell lineages also can go down, and you also see organ dysfunction. It should ring a bell that this patient might be having an immune dysregulation, probably might be ending up with HLH. So at that time, send in a serum ferritin. Based on the serum ferritin value, you can classify them as HLH unlikely, HLH possible, or HLH probable. Okay. If it's less than 500 micrograms per liter, definitely it's unlikely. You have to repeat all the labs, keep a watch on this patient. Probably some source identification might not be there, and that might be one of the reasons causing bicytopenia and fever and organ dysfunction. But in case you have it between 500 to 10,000, especially if it is more than 4,000, it is possible that this patient is going into HLH. Okay, at that particular time, use your H score. Okay, and if it is more than 169, probably it confirms the diagnosis of HLH. Whenever you see the serum ferritin is more than 10,000, it is probable. Usually can go ahead and start your immunosuppression at that particular time. Okay, so that is what is necessary. Usually, by and large, whatever you do, it has a higher mortality rate. That is the reason it is called a fatal disorder. Okay, so at this particular time, even if you do your when it's more than 10,000, most of the times the H score will be positive. Okay, so there are two criterias in HLH. You all know there is the 2004 criteria which you guys have to remember. Okay, so based on that HLH criteria, you know that it contains these following headings. Try and remember this as much as possible. You can either divide them as clinical or lab and laboratory. Okay, and additional testing, something like that. Okay, you have to remember, by and large, if any of the four criteria is present, then it is considered to be HLH likely. Okay, what are they? Fever of more than 38.2, splenomegaly, cytopenias, at least two cell lines. Okay, in that hemoglobin should be less than 9, platelets should be less than 1 lakh, or an absolute neutrophil count less than 1,000. Okay, hypertriglyceridemia that should be present. Usually what has to be sent as a fasting sample, that has to be usually more than 265 milligrams per deciliter, or else a fibrinogen level less than 150 milligrams per deciliter. Ferritin more than 3000 is also one of the criteria that you have to take in. The other ones are tissue based diagnosis, that is your hemophagocytes seen on biopsy, be it from marrow, spleen, lymph node, or even liver. uh, NK cell activity and soluble IL-2 receptor activity is something that is not routinely available. But yeah, you can mention these two as one of the criteria which are involved in the HLH 2004 criteria. The other thing you have to remember is the H score. H score, if you see, by and large, it's similar to what is seen in the HLH criteria. It usually consists of 9 parameters. The only problem is it's really difficult to do it from mind. Okay, because each score is different. The weightage for each particular score is different, and the overall score, if it is more than 169, the likelihood of HLH is higher. What they have done is they have done multiple validatory tests which have shown better predictability. Okay, so if someone asks which is a better score, definitely it's the H score. Okay, but by and large, remember HLH 2004 criteria, and remember the name as H score, score more than 169. If you have written this at least if you have written 60%, if you can recall out of this, say that they say for more than 4 criteria, if you have written at least 6 out of the 8 criteria, also it is good enough. Okay, don't be very adamant that yeah, I will remember all the 10. If you remember all the 8, really good. Okay, but don't feel bad that you can't recollect all. Okay, it's humanly impossible, especially when you're under stress. If you can recall at least 6 or 7 things, it's very good. Okay, so make mnemonics of your own, whatever you want, and remember it. Okay, so there are a lot of scoring systems. Most of you have kept asking. So make mnemonics or look for mnemonics which are already available as and when possible when you're studying. Okay. Management, you have to remember, it goes up in a systematic way. Write what you do regularly at bedside. Okay, you know that it is a particular score. It is only for 5 marks, right? So that is the reason it has gone in 3 pages. Okay, you first write about the diagnostic approach, criteria, then management. So you can finish it roughly in 2 pages. Okay, so firstly you'll do the labs because you need to use the scoring system. So what are the labs you ask for, the routine labs, the additional labs. Okay, especially if additional labs, what you focus is on viral etiology, etc. Okay, so mention about that. Okay, then you do additional testing like bone marrow aspiration, etc., to for looking for hemophagocytes. So this is something that you need to remember. Then you can write about your radiological investigation. So any question if they ask about management, so write about what you do. Okay, your investigations, then go to treatment. So if they're writing management, don't directly jump to writing your treatment per se. Write about how you work up and then you go for treatment. Okay, in treatment, as and when possible, if you know what is the goal, please mention the goals. Okay, in this particular HLH, whenever it is there, the only thing is know why it is happening, what is the inciting factor or the trigger. So you have to diagnose it early, start the supportive care, look for the etiology. Okay, start and manage accordingly after that. Okay, usually it's a multidisciplinary approach. Usually you have the hematologist and the oncologist also with you. Okay, and by and large it's a MDT management towards the management of HLH. Two protocols were famous. One is the 94 HLH protocol, the other one is the recent one, that is the 2004 HLH protocol. Only thing which was stark difference between the two is the inclusivity of the stem cell transplant. Earlier in 94 they were not including that, but right now 2004, based on the type of HLH or the etiology of HLH, you can include stem cell transplant. Firstly, you can divide this into 3 things, that is your first line therapy, second line therapy, and salvage therapy. First line usually consists of your drugs like anakilra, your interleukin receptor antagonists, steroids, methylpred, dexamethasone, hydrocortisone. Dexamethasone, the 2004 protocol and the 94 protocol have given a very clear way that they have to give. It is a tape, a higher dose in the starting and then taper it over a period of 8 weeks. Okay, that is what is usually given. Roughly 20 milligrams is what they start with. They have given the dose to be 10 milligrams per meter square. Okay, of dexamethasone, which roughly is 15 to 20 milligrams. Okay, so per day of dexamethasone. So you start it with 20 milligrams per day, then slowly taper it over the period of 8 weeks downwards. Okay, then you can also consider the use of IVIG as one of the first line therapies. The second line therapy, drugs like your JAK inhibitors, okay, your Janus kinase inhibitors like doxulotinib and barcitinib. Okay, these are the drugs that you can remember. Your JAK inhibitors, if you remember more than enough. Drugs like etoposide is also something they consider. Okay, other things like monoclonal antibodies have also been included in second line therapies. If both of them are not working, then you can think about salvage therapy. The question comes here, one thing which I've also forgotten to mention here, but that usually happens. See, this is what I also forgot to write when I was writing. So how will you choose? What is the cutoff factor? When will I skip from first line to second line? So you look into your head score. Okay, so if you feel that one of your parameters like your fever is not settling, bicytopenia is still worsening after 48 hours, probably if you see your inflammatory markers are still on the higher side, probably at that particular time you can also include the second line therapy, that is your patient is rapidly deteriorating. Remember, whenever you have a case of HLH, you are desperate. Okay, despite you doing everything, every possible thing, the patient might not survive. But yeah, this is how you can systematically treat your patient. Okay, salvage therapy include plasma exchange therapy, use of monoclonal antibodies, anti-interferon C monoclonal antibodies, and sometimes induction of chemotherapy. If all of this is done and you have this patient under some control, you can post this patient if at all he's actually fit for a transplant, you can think about doing a allogenic hematopoietic stem cell transplant. Okay, so this is in brief about the management if they ask for a 5 marker management of HLH. Okay, remember this is the 2016 WHO classification, primary and secondary. There are different ways. Okay, depends on the type of cells that you talk about, and that is how they've classified HLH as. Remember the 2004 criteria. Remember your H score. Okay, H score is really difficult to remember. Just remember score more than 169 is confirmatory for HLH. Okay, so this is by and large general considerations. Optimize supportive care, check for secondary infections. Okay, rule out all of this. If possible, then you start your management per se for that thing, that is your immune suppression therapy, increasing the immunosuppression. If everything is okay, once the patient is a bit stabilized, think about allogenic stem cell transplant. Coming to the last question, it's a part B of question number 10, withdrawal syndromes in the ICU, recognition and management. So, this can be one of those questions wherein you know something and you have to write an answer, and this will fetch you some good marks. Okay, so sometimes you would have got googly questions. This might look like a googly question for some people. Okay, they're like, withdrawal, what do I write? So, if you think, write your answers, after thinking probably for 1 or 2 minutes, you can formalize your answer and present it in a way that you can score marks in this as well. So always remember, whenever you get a bouncer, sit back for some time, use 1 or 2 minutes of that time, think what you know about it. It might be zero, but you can link that particular topic to something and then do. This is in that way a slightly easier thing because you see this quite often, and most of you have written a good answer. Whomever I saw, you started with writing alcohol withdrawal as main thing. Yes, good enough, but mention other things as well. By this, you need to understand that withdrawal syndrome, what it is. Correct, the question is very simple. It's a 5 marker. Only they want to know, how do you recognize it, how do you manage it. Okay, nothing more than this. Okay, so how do you recognize? Usually what happens is, a withdrawal syndrome refers to constellation of symptoms that follow cessation of a drug or a substance. So if you write this, they understand that you know what is withdrawal syndrome. Then if you write what are the etiology, it can be alcohol, drugs like opioids, benzodiazepines, any antipsychotics that the patient has been taking. So then coming to recognition. So what is recognition? That is nothing but your diagnosis. How do you go to the diagnosis? It can be the clinical features, right? You categorize them as signs and symptoms. Initially, when I started writing the answer, I just wrote down the things like agitation, restlessness, fever, etc. But the other way you can present it is like signs and symptoms, right? So you organize your thought, you can write it better. So in that, you can make your signs and symptoms and present it. Okay, so most of the signs and symptoms for most of the withdrawal syndromes are same. Okay, it's always associated with anxiety, it is always associated with restlessness, it can be associated with movement disorders like tremors, worst case scenario seizures. Okay, so you can classify these things. Sometimes what you see is autonomic dysfunction. Okay, it might be accelerated hypertension, tachycardia, sweating. Okay, or raise in temperature. Then mention about types individually. You can mention. Okay, you can go by talking about alcohol withdrawal. What do you use? There are tools which are present like your SIVA score or your short score, etc. Okay, SIVA stands for Clinical Institute Withdrawal Assessment of Alcohol. It actually has a very good sensitivity and specificity. Trust me, when I prepared also, I didn't know this unless I read specifically and then got to know. I just thought it is by and large, recognize this and give the answer as drugs, right? Give them, your benzodiazepines. Usually what we do is chlorodiazepoxide, right? You start this, and if it's an acute emergency, give haloperidol. So we thought that is just that, but there have been a very systematic tools which are present from a long time. SIVA score is one such score, SIVA AR. Okay, it stands for Clinical Institute Withdrawal Assessment for Alcohol Revised. Okay, it gives us the assessment for severity as well. Okay, if there is presence of delirium tremens, agitation, it starts with this. Worst thing what happen is it can be seizures. A SIVA score of less than 10, what you need to do is just observe this patient, probably might not worsen. Okay, uh, between 10 and 18, probably you might have to give a PRN type of a drug like benzodiazepines. If at all required, gabapentin. If the patient is extremely agitated, probably haloperidol. If the score is really more than 19, then it's a very high possibility that this fellow will develop uh, uh, you know um, withdrawal. Probably it's better to initiate these patients preemptively. Okay, so preemptively you can start these patients on benzodiazepines and go up on the dose and the type of drugs depending on the outcome. The other type of withdrawal which are seen in the ICU are opioid withdrawal. Patients might be on opioids for chronic pain. Okay, signs and symptoms can start with pain itself. Okay, because they have had sudden discontinuation in the ICU, probably for some other reason. Okay, they can present with piloerection, excessive lacrimation, mydriasis, which is being present, sleep deprivation, etc. So these are the things which you see in opioid withdrawal. Similarly, you see benzodiazepine withdrawal and sedative hypnotics, which are more or less similar. So this is by and large recognition of withdrawal syndrome. Coming to the management, you have initial workup. I told you routine labs and specific tests. Okay, you divide it like that, and then you can give it. Okay, routines you all know: complete hemogram, liver function test. Okay, to rule out any metabolic etiology for altered sensorium. Withdrawal syndrome is the differential diagnosis is something that you need to worry about. Okay, the best thing would be you have to mention about. Differentials also. If you write that, then you'll definitely get full 5 on 5. Okay, so radiology, you know, CT, MRI to rule out any organic causes. Start with step 1, that is your supportive care, recognition of the cause. Okay, correcting your confounders like electrolyte imbalance, hypoglycemia, pain management, early mobilization, and probably sometimes even family involvement. Step 2, to think about the cause oriented the issues, whether it is alcohol, opioids, okay, or any other sedative hypnotics. Try and bridge them. Whenever it is opioids, what they tell us, use drugs like uh, clonidine or buprenorphine. Okay, methadone also is something that you can think about. Okay, so step 3 is basically to think about prevention. So whenever you have patients on a long term drug, like be it opioids, benzodiazepines, look at the propensity for such patients to develop withdrawal. Okay, at that particular time, think about tapering or bridging these patients with some other less potent medications so that they do not develop withdrawal. So this is by and large what you need to write an answer if they're asking about withdrawal syndromes recognition and management. Okay, so one thing which I saw this, I hope this helps. Okay, this is actually there in 2023 update which they provide to us in the annual conference. Okay, you can go and read this chapter there. Okay, so this is where I saw one thing which was good. Okay, so by and large, you have to mention about each test which are doing when you're talking about workup. Okay, CIVA score, it's quite difficult to remember. Okay, it's also a very subjective tool. Just remember less than 10, 10 to 20, more than 20. That's a vague way to remember it. Okay, more than 20, definitely start. Okay, these patients are at a higher risk for developing withdrawal. Other type of scorings which they have seen are short score, like it is actually standing for sweating, hallucination, orientation, and tremor. Okay, so based on this they can do a scoring assessment and think that whether the patient is in whether a mild type of withdrawal, moderate type of withdrawal, severe withdrawal, and based on that you can choose your drugs. So this is something that I found on up to date. Okay, this is after I wrote the answer. Just looked into few sources which might help you guys. What they say is roughly minor withdrawal happens between 6 to 36 hours. Okay, so it can be a very small thing like a headache or diaphoresis or palpitations. Sometimes the patient can have diarrhea or vomiting. Okay, but usually the mentation is normal. Seizures usually occur between a period of 6 to 48 hours. Okay, it can be a brief GTCS, sometimes can be a worst case of status epilepticus. Hallucinations are usually seen in the first 2 days. Even delirium can happen within a span of 2 to 4 days. Okay, usually delirium tremens doesn't start on the first 48 hours. It usually occurs after 48 hours. So that is something that you should understand. If someone comes to you with alcohol history and you see that they were fine for the first 2 days, but after day 3 and day 4 you notice some tremors in them, probably it might be because of delirium. And such patients usually benefit with the initiation of benzodiazepines. Okay, thank you. So this actually concludes most of the things. Uh, so all the best, guys. So whatever answers you have written till now, if you have written 60%, be proud of yourself. Okay, you still have a lot of time. The whole idea was to boost your morale. Don't be saddened if you have not written, or you're like, oh, I forgot this, I forgot that. It is possible. All of us cannot remember 100%. We know that. And even if we write 50% right now, you look at it in a positive way, that you have for the 20, 30 days or 20 days more, that you can sit and build on. The goal is revision. Please revise. Okay, don't attempt reading newer topics towards the end of your preparation period. Just 1 week before, try and revise as much as possible. Okay, out of 10 questions, roughly 5 to 6 questions you will know the answer. Okay, just formulate it in your head. So prepare your answer in the head, telling that if this question is asked, I will answer it under these headings, and be done with it. Okay, don't explain beyond what is necessary. If you see, most of our answers are beyond what is necessary. Okay, try and complete it to the point which they've asked. Avoid answering unnecessarily. Okay, don't prolong your answers. If they have asked recognition and management, write recognition and management. If they've asked management with evidence, just write management evidence. Write it only to the point. Don't write etiology when it is not last, like we have written. Write in a few things. This is what I wanted to point out. This is where we go wrong, wasting our time and space. Okay, remember, both are constrained in your exam. Usually your exam will not be so lengthy, it will be shorter. Okay, so they will not give you such a bad lengthy paper. Okay, they will try and balance it out. So don't get scared if you are unable to complete the thing. Don't worry. Okay, so if anything is there, please feel free to join with us. Okay, after the theory exams, definitely we will be regrouping for practicals as well. Okay, so feel free to ask your doubts about anything during that time as well. So we are trying to help you as much as possible. Okay, we will be shortly sharing the details of the practical course as well. Okay, so once you finish this, by and large, this theory will be the foundation for your practical, so prepare well. Okay, so all the best. Definitely you guys will do well. Okay, hope to see you guys soon on the other side. Okay, is the online one is the online practical course. The other one is the on site, that is your face to face interactive session for practicals as well. The on site is planned in Bangalore sometime in the month of February. We would be definitely hoping to get your feedbacks. Okay, because we feel your exams, the thing released from the NBE says March, April, May, so we don't know when it will be. If you guys are interested about anything in that matter, we are planning to keep it tentatively towards the end of February. So please let us know your thoughts and inputs about the thing. Okay, we do have both. We are thinking of conducting online for people who cannot travel to Bangalore, but that would be different from what we do on site. On site would be a dedicated 2-day program. Okay, so definitely we will think of joining you guys there. Hope to see you there at that time. Okay, so yes, I think so you might get a video of this class here to one of you who texted on the chat box. Okay, so please watch out for the space for next things, and anything regarding your theory, please feel free to talk to us. Okay, sure. I think so. Navneet, they need to know about the Telegram link. We have not made any Telegram link as of now for this exit exam per se, but we will surely be, making a link for that. Okay, if at all we are planning to do our practical sessions at that time. Okay, so all the best, guys. Thank you for staying till now. Okay, that was really wonderful. That more than 50 odd candidates, joined in. Thank you so much. Bhuvana and Srihari, anything else you guys want to add?
Nothing. So you had covered most of it. All the best, guys. All the best.
Thank you.